Good afternoon, everybody. So welcome you all for CME program October 2024, organized by the College of Specialists in Rheumatology and Rehabilitation. As usually, today we have two important clinical presentations. First presentation by Dr. Nuwan Wijayalath, a consultant rheumatologist and rehabilitation specialist, teaching hospital Kalutara. He will be talking on the thrombocytopenia. It's a real case of SLE. Over to Nuwan.
Good afternoon, everybody. Thank you, sir, for the opportunity. I'm going to present a case about life-threatening thrombocytopenia. So my patient is Miss C, a 16-year-old O-level student. Her background is she was diagnosed with epilepsy at the age of 9, and she was on 3 anti-epileptics, and probably the highest dose, you can see the lacosamide 150, BD, and oxcarbamazepine 600 milligram BD, and levetiracetam 1.5 milligram BD. And she was on, fairly the epilepsy was controlled, and she was presented with 1 day history of fever and generalized ill health with lethargy for 2 days, and she had 2 episodes of vomiting, headache, faintishness, and she was menstruating when she was admitted, and it was excessive than before. On examination, there was ecchymotic patches all over the body. There was a pallor, significant pallor, without any jaundice, and the blood pressure was all right, 117 by 80. Normal parameters like saturation was completely normal. And 2 hours after the admission, she developed central chest pain with T inversions in lead 2, 3, and AVF, and V4 to V6 with sinus tachycardia. Troponin was positive. This is the ECG. You can see the T inversions. And at that time, the available investigations was the hemoglobin was 5.4, and the platelet count, you can see it was 6,000 with normal white blood cell count, and CRP was normal. And the medical team, because I haven't seen the patient at this point, the medical team was, has referred this patient to cardiology team, and they have arranged to the echocardiogram. There were no regional wall motion abnormalities. The ejection fraction was 60%. And it was attributed to juvenile ECG pattern of T inversions and suggested to correct hemoglobin after finding the cause of anemia. And patient was treated with IV tranexamic acid to control menstrual bleeding at that time. These are the investigations available. The ESR was 39, and retic count was obviously increased. The INR was normal, APTT was normal, D-dimer was normal, and LDH slightly increased. The UFR, she had field-full red blood cells, obvious, patient was menstruating, and albumin was 2+. The creatinine was normal, electrolyte was normal, ALT and AST was raised, AST more than ALT. Then the ultrasound scan of the abdomen was done because she had unexplained abdominal pain as well with all these features. And there was gallbladder wall edema and thin layer of free fluid, and they have suspected leak-in phase of dengue. So patient was suspected to have dengue hemorrhagic fever, as there was fever, thrombocytopenia, there was bleeding, menorrhagia, and there was mucocutaneous bleeding as well, that was ecchymosis. And the blood picture, unfortunately I don't have a slide, but the blood picture was hemolysis with few fragments, and it was normochromic, normocytic, and there were nucleated red blood cells, polychromatic red blood cells. In white blood cell line, the neutrophils showed left shift, platelet was significantly low, and the ongoing bleeding with thrombocytopenia they have suggested. So after that, the dengue NS1 antigen was done, it was negative, and platelet transfusion was arranged because there was ongoing bleeding and low hemoglobin because of this life-threatening nature of bleeding, because hemoglobin was very low. So they have arranged platelet transfusion as well, and blood transfusion also planned later. Again, the blood picture was sent before the platelet transfusion, and patient had platelet transfusion. The blood picture had evidence of hemolysis with thrombocytopenia, and they have suggested ongoing infection and suspected Evans syndrome. Then the Coombs test was sent because there was hemolysis and thrombocytopenia now. Third day, the hematologist suggested prednisolone high dose 1 milligram per kg per day, as Evans syndrome was suspected, and blood transfusion to correct hemoglobin, and IV immunoglobulin started. So this was at the morning, and in the afternoon, patient developed headache. 2 hours later, with the onset of headache, patient developed 1 episode of generalized tonic-clonic convulsion and developed post-seizure drowsiness, and GCS deteriorated, and patient was admitted to ICU. And at that time, the non-contrast CT was done, it was normal. So obviously, patient was started with IV ceftriaxone and IV acyclovir after sending blood cultures, but LP was not attempted, the obvious thrombocytopenia. The DAT was negative, then IVIG was stopped. And the prednisolone was not started as there was suspected CNS infection and developed another episode of seizure. So at that time, the ESR was 39. CRP was increased from 11.6 to 110. The repeated ESR was also 39 at that day. So there is discrepancy, ESR 39, CRP was increased. So topiramate was added for, there were 2 episodes, so apart from those 3 drugs, now the topiramate was added. And again, LP was not done due to severe thrombocytopenia. Then the patient was referred to our team. So the summary was 16-year-old girl with past history of epilepsy at the age of 9. And patient had fever, thrombocytopenia, Coombs negative hemolytic anemia, and patient had ischemic type of chest pain, seizures with altered level of consciousness, and she had 2+ albuminuria with normal renal functions. And I have done urine SCG, obviously it was negative. So then the question was, is it TTP? Because with thrombocytopenia, hemolytic anemia, and there is organ dysfunction. Patient had ischemic type of chest pain, patient had neurological dysfunction. So is it TTP? And I suspected about SLE as well, because multiple organ involvement, hematological involvement, neurology, and so on. So I have done urgent hematology referral, and I specifically asked for this microangiopathic hemolytic anemia. Then the hematologist was, she called me and confirmed there is microangiopathic hemolysis, and she checked the other blood pictures. Obviously, the previous blood pictures, there was no evidence of microangiopathic hemolysis. So at this point, the third blood picture, she said there is microangiopathic hemolysis. And NA titer was sent with dsDNA assay. At that time, the menstruation has stopped, so UFR was repeated. And Hep B, Hep C, and HIV serologies were requested. And I suspected about macrophage activation syndrome as well because there was a disproportionate ESR with CRP. So fibrinogen and serum triglycerides test was requested. So this was the blood picture. You can see these histiocytes, and you can see microspherocytes and few nucleated red blood cells. So this is classic picture of microangiopathic hemolytic anemia. So the blood picture was that, and the triglycerides were normal, plasma fibrinogen were normal, serum ferritin was marginally elevated, not gross. It was 387. So the macrophage activation syndrome part was over, so it is definitely not macrophage activation. The TTP diagnosis was confirmed now because there is ongoing microangiopathic hemolytic anemia and associated organ dysfunction. And we have arranged 3 pulses of IV methylprednisolone. First pulse given that day itself. I have discussed with the consultant transfusion physician and started plasma exchange. Also the calcium vitamin D prophylaxis was started. So repeat UFR showed 3+ proteinuria and feel full red blood cells without having menstruation, and we have done dysmorphic red blood cells, and those were also positive. We had the facility of doing these dysmorphic red cells at the hospital, so it was very quick, and they confirmed that there is dysmorphic red blood cells in the UFR. And urine protein creatinine ratio was 6.11, showing nephrotic range proteinuria. And now the question is whether due to TTP itself or whether there is lupus nephritis. So these are the pre-plasma exchange. This is the pre-plasma exchange full blood count. You can see HB was 5.9 and the platelet was 14,000 at that time. And nephrology opinion was taken. So here there is dilemma. Obviously, due to TTP also you can have glomerular leakage of blood cells and proteins, but patient had gross hematuria plus proteinuria and multiple organ dysfunction, so we can't exclude lupus nephritis at this point. So if that is so, probably class 3 or 4, but luckily renal functions were preserved. But renal biopsy couldn't be done due to severe thrombocytopenia. So at that time, so the ANA was the key investigation that we needed. And we continued steroids with plasma exchange. And ANA was positive, which is strongly positive, 1 in 1,280. And again, dsDNA was positive. So there is no doubt about the diagnosis of SLE now, TTP plus SLE. So we have started hydroxychloroquine as well. With plasma exchange, actually patient was started getting better because patient was like unconscious when we start plasma exchange. Actually, second day itself, patient improved consciousness. She was very rational in answering questions. So that is the miracle by plasma exchange. It was drastically changed the outcome. So first plasma exchange itself. So even with the 4th cycle of plasma exchange, the platelet was 76,000. So we started thinking of rituximab, but according to guideline, you all know, we have to think of rituximab during first 2-3 cycles of plasma exchange. But we had hope because it was slowly rising, but even with 4th cycle of plasma exchange, it was 76,000. We started thinking of rituximab, but after 4th cycle, patient had deterioration in her vision in right eye. So what do you think? What are your thoughts regarding her visual impairment? So this patient had visual impairment in her right eye. That was quite significant. Any thoughts? So this is not the retinal image of the actual patient. Actually, this is an image of left eye. This was taken from the internet. Unfortunately, we couldn't have the opportunity to take pictures, but I have seen the fundus, but the fundus is exactly look like this. So what do you see? Obviously, you can see the disc edema, right? The optic disc is swollen. And what else? You can see the veins are engorged, so dilated. And what else? Can you see retinal hemorrhages as well? There are few retinal hemorrhages as well. So what is this? What do you expect to see? So this is central retinal vein occlusion. So patient had central retinal vein occlusion. So this is the findings. So we have done ophthalmology referral, and the diagnosis was confirmed, and started measures to reduce intraocular pressure and the inflammation. And we have asked specifically about hydroxychloroquine, because we have to continue hydroxychloroquine, and ophthalmologist confirmed that we can continue hydroxychloroquine because the pathophysiology was different. And local timolol and Navan eye drops prescribed, and they have planned very close follow-up. So third day, actually, we have planned for these retinal images, but she started to see vitreal hemorrhages the next day on itself. So now, we have done 5 cycles of plasma exchange. So the HP was 7.7. Now platelet has risen to 107,000. We started thromboprophylaxis, giving low-dose aspirin plus enoxaparin, because so this is thrombotic microangiopathy. I will describe later. So there is bleeding, plus there is high risk of thrombosis as well. So we have started thromboprophylaxis, low-dose aspirin with enoxaparin. And so we have continued the plasma exchange, because we have to achieve the goal of 150,000. So that is the target we should achieve as a therapeutic target. So plasma exchange was continued. So what is plasma exchange? So plasma exchange is removing patient's total plasma volume and replacing with replacement fluid. So we use FFP, and we did daily plasma exchange. So we have a patient with TTP, the mortality is 90%. So you are dealing with a patient with very high mortality. So plasma exchange reduces mortality from 90% to 10 to 20%, right? And also it repletes ADAMTS13 and removes autoantibodies. I'm going to describe those things later. You already know, I'm sure. So we had multidisciplinary team meeting, and we had discussions. So now there were renal involvement, hematological involvement, and ultimately thrombotic manifestations in the eye. And we decided to proceed with 2 doses of rituximab, 2 weeks apart, and to tail off steroids with the introduction of MMF. I know there were kind of big arguments, because the rituximab is not the first line for lupus nephritis. So if you are suspecting it, and if you are going to start rituximab for TTP, and this is not the good time to start rituximab, but we all agreed to proceed with rituximab to protect the kidneys as well as to improve the mortality further by giving rituximab according to the evidence. So we have arranged 2 doses of rituximab, but luckily it was after like 8 cycles of rituximab. So we had some kind of delay, we accept it. But so another question, so if you are going to give rituximab, for a patient who is on plasma exchange, so how are you going to give it? Are you going to stop plasma exchange? So that is my additional question. So if you are giving rituximab, if you are planning to give rituximab to the patient who is on plasma exchange, suppose this patient is like after 5th dose, so platelet count is 107,000, so you are going to give rituximab. Are you going to stop plasma exchange? Anybody? No, you can't stop plasma exchange. In that case, you have to give rituximab, like, every 3rd day. So the rituximab for these TTP is 375 milligram per square meter. So you have to give it like, every 3rd day rituximab. But this patient, when we gave rituximab, it was after plasma exchange, so we have spaced it out nicely, 2 weeks apart, 1 gram, because we covered renal plus this TTP. So this is not like PO TTP or PO renal. So we gave 2 doses. So it was after like a big discussion. So we had 1 hour discussion after that. So with all the stakeholders, we gave rituximab. Actually, the decision of rituximab was facilitated with the result of positive dsDNA. So that was reinforced. So we should give rituximab. And also we planned for 2 weekly eye reviews to monitor progress and to monitor deterioration and to act accordingly. And we decided to continue hydroxychloroquine despite having macular edema, as pathophysiology is different. And also we agreed to continue thromboprophylaxis with enoxaparin for further 6 weeks and to continue, TPE until target platelet 150,000, but this discussion happened the day of 7th cycle of total plasma exchange, but 7th day after doing it, it was 173,000. So we gave further 2 plasma exchange, that was the guideline. So, and we stopped it. And to do interval renal biopsy for histological confirmation, because that was not the good time to do renal biopsy. So this was after the 6th cycle of plasma exchange, it was 154,000, and the blood culture came as no growth, patient was completely well, and 8 cycles of plasma exchange was completed. So after completion of plasma exchange, right, so now the platelet count was normal, and proteinuria, the UFR, there was 2 plus proteinuria plus 3 plus hematuria. So now what? So the TTP, not grossly that now TTP has resolved, the platelet count has risen, but still there is 2 plus proteinuria plus 3 plus hematuria. So this might be due to TTP itself, because the renal damage is ongoing for a while. It was damaged now. So this might be due to the damage itself, or this might be due to lupus nephritis. So that was the argument. But as dsDNA was positive, so we thought of better to be on safe side, so we thought of this as lupus nephritis. So this was the plan from rheumatology side. To continue hydroxychloroquine, to tail off prednisolone quickly, and to maintain low dose of steroids with mycophenolate mofetil, and to arrange interval kidney biopsy to be certain about the diagnosis. So this was the latest retinal image of right eye. These are the actual, the retinal image of the patient. So what can you see? This is the actual retinal image of the patient. Anything you can see? Can you see the macula? So there is macular hemorrhage. So there was macular hemorrhage, and this is the left eye. So anything significant? So this is just the light reflex. So the left eye was normal actually. In left eye initially there was impending central retinal vein occlusion, but later on it was, it was resolved. So the pathology was only at the right eye. So the eye surgeon, they decided to go ahead with Avastin, intraretinal Avastin, and they are going with a discussion with VR surgeon now. So we'll come to the discussion of TTP. So what is TTP? So TTP is a thrombotic microangiopathy, as I said. So then what is thrombotic microangiopathy? So what do you mean by thrombotic microangiopathy? So it's an umbrella term. So it has few characteristic features. There should be microangiopathic hemolytic anemia, thrombocytopenia, and there should be occlusive microvascular or macrovascular disease. So the thrombocytopenia and microangiopathic hemolytic anemia are the must. Right. So what are the differential diagnoses for microangiopathic hemolytic anemia? Even in Evans syndromes, so you can see microangiopathic hemolysis, right? In TTP, DIC, HELP syndrome in pregnancy, malignant hypertension, some kind of viral infections like cytomegalovirus, herpes simplex, and bacterial infections like meningococcal, pneumococcal, and hemolytic uremic syndrome. Even in scleroderma, they have described this microangiopathic hemolytic blood picture, lupus nephritis, and catastrophic APLS. So that is also a 1DD. So thrombotic thrombocytopenic purpura, TTP, is a life-threatening medical emergency. The mortality is 90%, so definitely it is a life-threatening. So the pathophysiology is a deficiency of metalloproteinase called ADAMTS13. So what is this ADAMTS13? So this is a metalloproteinase, so which is produced in the liver. So what does this enzyme do? Actually, this cleaves large multimers of von Willebrand factor. So what is von Willebrand factor? As we all know, so in hemostasis, there is vascular response, platelet response, and clotting response, right? In platelet response, the von Willebrand factor plays key role for platelet aggregation. So in circulation, usually there are large multimers, like ultra large multimers. So these are cleaved into small molecules in normal well-being. These will be cleaved into normal like size molecules by these ADAMTS13. So what happens if this enzyme is deficient? So there is accumulation of these large multimers of von Willebrand factor, and platelet will go and bind to those large multimers and form a platelet-rich clots. So what happens if you give further platelets then? So in thrombotic thrombocytopenic purpura, if you give platelet transfusion, what happens? Those platelets also will go and bind those multimers, and it aggravates the thrombosis. So that is why in TTP, the platelet transfusions are contraindicated. So that is what I described. So I'm skipping slide. I don't know whether I'm exceeding my time. So this is why the platelet transfusions are contraindicated. And here in TTP, what are the therapeutic principles? So there are few therapeutic principles: to remove clots and to remove large multimers of von Willebrand factor, to replace ADAMTS13 enzyme, and to decrease the antibodies against ADAMTS13, and to screen for thrombotic complications, because now you know why the thrombosis is increased in TTP. So now you know the rationale. So we are going to screen for thrombotic complications and prophylaxis against thrombosis, and to find the cause for these autoimmune response and manage accordingly. Because obviously this is acquired. The patient is 17-year-old. She was completely well, and later on she developed this thing. If the ADAMTS13 deficiency is due to PO production deficiency, so it should be congenital type of this thing. So now acquired in later life. So obviously this is autoimmune response. So international consensus, define this TTP as this. So microangiopathic hemolytic anemia with moderate or severe thrombocytopenia with associated organ dysfunction. What are the organs? Neurological, cardiac, renal, or gastrointestinal. And also you have to measure this ADAMTS13 level. So if it is less than 10, then you define this as TTP. So you need organ dysfunction, you need thrombocytopenia, you need microangiopathic hemolytic anemia, plus you have to demonstrate the deficiency of ADAM-TS13. Unfortunately, we don't have this facility. Even in UK, there are only 11 centers all across the UK to do these ADAM-TS13 level. Those are the dedicated TTP centers. So if we diagnose TTP, like even at teaching hospital, so during my overseas training, I was in a teaching hospital, but we had to transfer patients. I had one patient during my training period, so we had to transfer to Birmingham. So I was in Wolverhampton, so we had to transfer to Birmingham QE Hospital to get this plasmapheresis, because we have done first plasmapheresis, and to manage accordingly, we had to send the patient, because that is a must. So that is the UK protocol, so we have to send the patient. So only those hospitals have that facility to monitor these ADAM-TS13, so no point of talking about Sri Lanka. So the clinical features are, thrombocytopenia. So these are the clinical manifestation. Neurological can be anything: confusion, headache, hemiparesis, seizures, aphasia, anything. Focal neurological deficit, so renal impairment, proteinuria, hematuria, cardiac, chest pain, might be heart failure, hypertension, MI, acute cardiac arrest even. So those are the TTP clinical features. And in GI tract, abdominal pain, pancreatitis, gut ischemia. And there are non-specific symptoms as well: fever, pallor, jaundice, fatigue, arthralgia, myalgia. Those are also features. Those are non-specific, obviously. Can be anything. And in TTP, the investigation, are like this. The coagulation screen is typically normal. You get normal APT, TPT, INR. And, the troponin level, this patient had positive troponin. So in TTP also, they describe, troponin can be increased in TTP. So that is a positive finding. Even TTP itself, without myocardial infarction, you will get positive troponin. And it is a bad prognostic marker in a way. So it six-fold increase in mortality. And we have to do virology screen, because we are going to give certain kind of, the biologics, rituximab. There is a thing called caplacizumab. We don't have, but the dedicated centers have those fancy stuff. So as I said, so TTP is a medical emergency. The plasma exchange should be commenced within 4 hours. So that is the recommendation. Sometimes, you might be in a periphery where plasma exchange is not available. So at that time, you have to give FFP. At least it repletes at ADAM-TS13, and after giving FFP only, you have to transfer. And the transfer should be immediate, where the facilities are available. But luckily, we, in Sri Lanka, every teaching hospital have this facility where the transfusion physicians are available. And a lot of district general hospital also have this, plasma exchange facility. If you are in a periphery where plasma exchange facility is not available, so you have to give FFP. So at least, so that saves life. So management should be ideally in intensive care unit, and also it needs VASCAT. So obviously, priority should be to initiate plasma exchange over investigations such as neuroimaging. So you can't prioritize doing CT and stuff, but you have to do plasma exchange, as an emergency. And we have to give high-dose steroids, IV methylprednisolone, or steroids, high dose, but IV methylprednisolone is preferred. So, as I said, if plasma exchange unavailable, so you have to give FFP and then do transfer. We use, solvent detergent treated plasma. So these are the hospitals available. The 11 TTP centers across, UK. And our therapeutic target is the platelet count of 150,000 and do 2 more plasma exchange following a remission. After achieving the target of 150,000, we have to give 2 more plasma exchange, and also to continue steroids. You can start tapering steroids by 2 weekly interval. And what are the other therapeutic modalities? So there is, monoclonal antibody for this. I have seen, this drug being used, but, so the patient was transferred to our hospital to continue this drug. So at that time, I have seen the cablasizumab. So 10 milligram was the dose. It was given in subcutaneous form. It is a monoclonal bivalent humanized immunoglobulin fragment. Actually, it binds to von Willebrand factor and it prevents the binding of platelets. So that is how it prevents aggregation of platelets around von Willebrand factor. So, but before giving this cablasizumab, so you have to demonstrate low level of ADAMTS13. So that is the prerequisite. Otherwise, the CCG, the Commission and agency won't approve this. So you have to do the level of ADAMTS13 level before starting cablasizumab. And you can give, if you are lucky enough to do these ADAMTS13 level, you can give it pre-plasma exchange. So in that case, you have to give IV the first dose. The later on, it is daily subcut dose of 10 milligram. So this is the recommended treatment in UK and only available in TTP centers, but definitely not in Sri Lanka. So rituximab, this is the chimeric, the monoclonal antibody against CD20. And if started, so the mortality benefit, if started within 3 days of admission or, doing plasma exchange, it will reduce the number of plasma exchange and number of days in ICU and number of relapse rates and mortality. But, we were delayed. So that was we had discussions. So, obviously this was discussed and managed. So recommended the dose interval, weekly 4 doses, 375 milligrams square meter. And if, as I said earlier, if it is during plasma exchange, rituximab should be given, every 3 to 4 days because of this monoclonal antibody clearance. Otherwise, it is weekly. So with that, I'm going to conclude my talk. I would like to see any questions, and thank you very much. Okay, in the absence of questions, thank you very much. Yes. Yes. So there were a lot of, discussions, why this epilepsy. So one argument is this could be, long-standing, evolving SLE. Because since the age of 9, patient had epilepsy, and it was quite resistant. You saw the amount of drugs that she was on. Because, so due to that reason, because it is quite resistant, it's a good question. So quite resistant epilepsy. Patient had kind of, throughout her history, the anti-epileptic doses were escalated. And even with that, patient had some kind of fit. So probably this could be a part of neuropsychiatric SLE that we don't know. We have to do all these investigations. I think Mahesha will discuss about these. What are the investigations if you are suspecting neuropsychiatric SLE? The other thing, seizure attacks during admission, we suspected it is kind of neurological dysfunction in TTP or kind of SLE itself. Any other questions? Okay, thank you very much then.
Yeah, thank you, Nuwan, for a very interesting presentation. So our next presenter is Dr. Mahesha Karunarathne, and she will be talking on the conundrum of diagnosing neuropsychiatric SLE, current and imaging approaches. Over to you, Mahesha.
Good afternoon, everyone. I'm Dr. Mahesha Karunarathne. So, the topic for today's talk is diagnostic conundrum of NPSLE, current and emerging approaches. So, in next 25 to 30 minutes, I will be talking about a bit about pathophysiology and the syndromes of NPSLE, and current disease markers and novel markers and novel neuroimaging methods. A bit about steroid-induced psychosis because it is relevant for the patient I am going to talk about. So I would start with one of our patients. This is a 35-year-old female, a mother of one child, and she was diagnosed to have SLE in 2019 in Anuradhapura Teaching Hospital. And during that time, the patient has had postpartum psychosis, and with further investigation, she had been found to have positive ANA, dsDNA, and supportive other criteria for SLE diagnosis. And since then, she had been on MMF. And but even with MMF, the patient has had several psychotic episodes in between and was defaulted recently. And however, she presented to our hospital at RRH with increased hair loss, facial rash, loss of appetite, and generalized weakness and anemic symptoms. And on examination, she had mala rash, pallor, and alopecia, and was investigations wise, she had high ESR, normochromic normocytic anemia with lymphopenia of about 300 absolute lymphocyte count. And evaluating the patient, the whole history and the investigations, the patient was managed as acute lupus flare-up and was started on prednisolone 1 mg per kg together with MMF. And after about 1.5 months, she presented to medical casualty ward in Ragama hospital with severe psychotic symptoms. And according to the mother, the patient had been well compliant with the medication and was on prednisolone 40 mg together with MMF. And she had no fever, no evidence of CNS infection, no past or contact history of TB, and no sexual promiscuity. And on examination, she had mala rash and no other significant neurological symptoms except increased talkativeness and wandering, disinhibited behavior. And investigation-wise, she had further lymphopenia. ESR also was high 45, but CRP normal. Procalcitonin was normal, and C3, C4, which was not affordable, And septic screening, CSF full report and culture, thyroid function test, CT brain, all were normal. Though we planned MRI brain, it was not done in acute stage because the patient was acutely disturbed, and the EG was, however, normal. So these were our differential diagnosis during the acute presentation. So as you can see, the differentiating between these diagnoses was crucial because the management is drastically different in each differential diagnosis. So if it's acute neuropsychiatric SLE, that is primarily correlated with SLE, the patient needs aggressive immunosuppressants. And if it's steroid-induced psychosis, the patient needs rapid tailing off of steroid. And if it's CNS infection, the patient should be off immunosuppressants and should be on antibiotics primarily. And if it's primary psychotic episode, the patient does not need any immunosuppressants or IV antibiotics. It's only the antipsychotic drugs which are needed. So as you can see, the diagnosis is a bit difficult here, and I would come up with the discussion now. So nervous system is one of the major organs affected in SLE, and the true prevalence of neuropsychiatric SLE is unknown because of the heterogeneity of the clinical manifestations, and also due to the different study population and study methods that are used to assess the prevalence. And this NPSLE is one of the serious and least understood lupus presentations. And also it's different from other aspects of SLE because its development without serological changes. So as I told, it encompasses a variety of neurological and psychiatric signs, and often hard to distinguish from SLE unrelated events. I will talk a bit about pathophysiology because it's important in discussing about the novel immunomarkers. So actually the exact immunopathogenesis is a bit complex and bit unclear. What is described in literature is mainly ischemic and autoimmune mediated neuroinflammatory pathways. So this ischemic injury is mediated by antiphospholipid antibodies, immunocomplexes, and complement activation. So the antiphospholipid antibodies play a predominant role in ischemic pathway. So it can cause intravascular thrombosis, subclinical atherosclerosis, which can lead to focal neuropsychiatric manifestations. And also it can cause direct neuronal damage by inducing oxidative stress, which can cause diffuse manifestations. So, according to studies, antiphospholipid antibody positive patients are twice as likely to develop NPSLE than APL negative patients. And complement activation also is related with psychosis and cognitive dysfunction. So, the other pathway, autoimmune mediated neuroinflammatory pathway, so complement activation enhanced the permeability of blood-brain barrier, intrathecal migration of neuronal autoantibodies, and local production of pro-inflammatory cytokines are described in the pathogenesis. So increased blood-brain barrier is essential for autoantibodies to enter the brain and then bind to neurons, which cause apoptosis and subsequent pathophysiological process. And also blood-cerebrospinal fluid barrier is also recently recognized as a process as a site of this pathophysiological mechanism. Autoantibody-induced inflammation. There are few autoantibodies which are described. So this anti-NR2A and anti-NR2B subunit antibodies, these are a subset of anti-DSDA antibodies that cross-react with epitopes on the subunits of NMDA receptors. So they damage the blood-brain barrier and penetrate the CNS, and it's closely related to the psychiatric manifestations of NPSLE. And these anti-endothelial cell antibodies, they also contribute to the cerebral vasculopathy and correlate with the psychosis and depression. Anti-ribosome P antibodies, they induce concentration-dependent neuronal dysfunction and apoptosis, and it's a strong marker associated with psychiatric NPSLE, NPSLE, that is psychosis and depression. Cytokine-mediated inflammation is also described. So this tumor necrosis factor like weak inducer apoptosis that cause an important role in blood-brain barrier disruption and accelerated neuronal apoptosis. And interleukin-6 is thought to have the strongest positive association with NPSLE. That's the strongest positive association of cytokine in NPSLE. And it causes destructive effect on nerve cells and found in patients with acute confusional state and psychosis. Interferon alpha also has a significant role in this. Brain resident and infiltrating cells, mainly the microglial cells, they have an active role in pathogenesis of NPSLE by regulating the blood-brain barrier function. So these are the American College of Rheumatology described syndromes of NPSLE. There are 19 syndromes. Central nervous system manifestations, there are 12 syndromes. Peripheral nervous system associated manifestations, there are 7 syndromes. So though these are well described as this, it's very difficult to diagnose NPSLE because to relate these syndromes to directly to the SLE, that is the problem of that's the problem of diagnosing NPSLE. So the challenges are these symptoms themselves may be mild and non-specific, and there's no specific objective histological laboratory imaging findings that can confirm the diagnosis. And also the patients might have other risk factors that are associated, and also they can also cause the clinical syndromes that were shown earlier. And also these neuropsychiatric manifestations, mainly the psychiatric manifestations, may be due to the emotional burden of having a chronic disease or due to adverse effects of drugs, mainly steroids and hydroxychloroquine. There are adverse effects that can cause psychiatric manifestations. And also these manifestations can occur independently of overt SLE activity. So let's talk about the conventional markers of disease activity that we come across in our practice. So CRP and ESR levels, they may increase in the musculoskeletal disease but may be normal in neuropsychiatric SLE. And complement levels also, although they are typically accompanied with active SLE, may be normal in 66% patients with active neuropsychiatric SLE. And anti-dsDNA antibodies also, they are highly specific for SLE and tend to correlate with the disease activity, but have a limited utility in isolated NPSLE, and also found only in 70% of NPSLE, and levels do not appear to correlate with the psychiatric disease activity. Anti-Smith antibodies also have shown to associate with neurologic disorders. So these antiphospholipid antibodies, they can be measured. They can be measured in serum and CSF. Cognitive disorders, the patients with cognitive disorders have been reported in 54% of APL positive, and also mood disorders are associated with beta-2 glycoprotein positive antibody positivity. And CSF also, CSF findings are also not specific for NPSLE, although pleocytosis, protein elevation, and elevated IgG, albumin index, they have been described mainly in aseptic meningitis and demyelinating conditions. When the patient comes with these psychiatric manifestations and cognitive disorders, the utility of the cerebrospinal fluid analysis is not that beneficial. EEG also has low sensitivity and specificity. It may show diffuse low wave activity in diffuse cerebritis, and in focal neurological signs there may be some focal changes as well. So when we take neuroimaging, so the conventional MRI is the utmost important neuroimaging modality, because it can identify small vessel disease, large vessel disease, inflammatory signs, inflammatory lesions, and they can assess. It can be used to assess the chronicity of the cerebral disease and can rule out other causes. But the findings do not appear correlate with the SLEDAI activity and anti-dsDNA antibody levels or complement levels. And also, the problem with the conventional MRI is it does not have the spatial resolution that is needed to detect microvascular involvement, and the microvascular involvement is there in up to about 42% of patients with neurological manifestations, but the conventional MRI has failed to demonstrate that. So the specificity of neuroimaging is also about 60 to 82% for MRI. So other than this neuroimaging and immunomarkers that we use in current practice, we can assess the cognitive impairment using several scales that are described in EULA guideline. So the comprehensive neurological testing is considered as the gold standard, that is the automated neuropsychological assessment matrix. But the problem with this is it takes about 1 hour time, and it's time, cost and training required. The significant time, cost and training is required, so it's not widely practiced. So instead of that, mini-mental state examination and Montreal cognitive assessment is used as screening methods, and these both show moderate to high specificities for cognitive impairment in SLE patients, where MOCA has higher sensitivity. So now I will describe you about the emerging approaches of diagnosing NPSLE, the novel immunomarkers. So this anti-NR2 antibodies, they can be detected in CSF, but not in the serum, and the levels correlate with the CNS disease activity, and the seropositivity associated with 1.6 fold higher odds in NPSLE. And this anti-UCHL1 antibody, that is a marker that develop in response to autoimmune injury to neural tissue, can be detected in CSF and serum, and the specificity is high, 92% for NPSLE. And this anti-ribosomal P antibodies, they can be detected through this ELISA and immunoblot blood, or in CSF they can be done, and the sensitivity and the specificity is 37 and 96% respectively. Though I describe this as such, these are not usually available in Sri Lanka, even in the private sector. So these are the emerging immunomarkers that is used in mainly the studies in this Western world and so on. So these cytokines as immunomarkers, interleukin-6. This interleukin-6 is the CSF interleukin-6 has shown a better utility than the serum interleukin levels. And but the problem with this is it does not distinguish NPSLE with non-neuropsychiatric SLE, intracranial infections, or non-inflammatory neurological disease. But anyway, that can be used to differentiate corticosteroid-induced psychosis and other non-inflammatory psychiatric disorders. These are the few cytokines that are described in literature. And markers of blood-brain barrier disruption or neural damage are also used in our world. This can there's possibility in utility of these agents to distinguish NPSLE from non-NPSLE. So the novel neuroimaging studies, so I described you about the problems with the conventional MRI earlier. So this novel neuroimaging studies, in contrast to conventional MRI, they are sensitive to physiological and microstructural tissue change that occur in brain. So they can reflect the altered perfusion or neurometabolite changes that occur in NPSLE, so have a better result in diagnosing NPSLE. So these are few neuroimaging methods. So this diffusion tense imaging, magnetization, transimaging, these are not available in Sri Lanka, but magnetic resonance spectroscopy is available in private sector. So it produces a spectra of nuclei that enable quantification of neuronal metabolites and the cellular function. So this is described as a good imaging modality that can be used to diagnose NPSLE. So this is the MRS scan, and this SPECT scan, it also utilizes it is a nuclear imaging method and utilizes a radio tracer to highlight cerebral blood flow and perfusion. And this FDG PET, it also utilizes radio-labeled glucose to highlight the cerebral metabolism. These both investigations are not available in government sector, but it's available in private sector. Functional MRI is also described as a good modality of neuroimaging in diagnosing NPSLE, this SLE changes in brain. These are the novel neuroimaging modalities that are described in literature to diagnose NPSLE. And though these were described as such, there's no sufficient reliable method actually, because there are ups and downs of the findings and the specificities of these novel imaging modalities and novel immunomarkers as well. So it's a bit, after describing all these, it still remains a bit of a conundrum of diagnosing NPSLE. So it's mainly the clinician's assessment of the patient. So and also that might decide the further management of the patient with regard to NPSLE. So since our patient had, with regard to our patient, I would describe a little about steroid-induced psychosis as well, because our patient, she had a differential diagnosis of steroid-induced psychosis. And this is actually a dose-dependent disease manifestation. And severe psychiatric illness was uncommon with doses less than 40. And usually what is described is affective disorders, including mania, depression, and mixed status. And it's said that it occurs within the first 1-2 weeks of steroid commencement. And short-term corticosteroid therapy, they correlate with euphoria or hypomania, whereas long-term therapy associate with depressive symptoms. And the female gender, concurrent lupus nephritis and hypoalbuminemia, they are more prone, the patients with those risk factors are more prone to get steroid-induced psychosis. So what happened to our patient? So on evaluation, the patient manifested SLE activity by this presence of malar rash, lymphopenia, and high ESR. And this during the acute stage, we could not find any other organic cause, and the patient was severely disturbed, so we had to intervene without waiting. So what we did was we started IV cyclophosphamide straight away. And also, when the patient was referred to the psychiatry team, they also raised the probability of steroid-induced psychosis, because the patient was on steroid prednisolone 40 milligram during that time. So considering that, we rapidly tailed off steroids, and also the patient is on antipsychotics. Now the patient is well, and her ESR and lymphocyte count is normal. So the diagnosis, whether it's PO and NPSLE or whether there's a component of steroid-induced psychosis, is still controversial. But anyhow, the patient's condition is now better. So the take-home messages. So NPSLE, it's a heterogeneous and non-specific clinical syndromes are there. And the recognizing NPSLE is very important, because it changes the management drastically. And serological and CSF markers and neuroimaging findings often do not mirror disease activity. So these novel immunoinflammatory markers and imaging modalities should be considered. And also there's the importance of diagnosing algorithm, the development of the diagnosing algorithm for NPSLE, so that it could be easily diagnosed. These are my references, and I would like to acknowledge my trainer, Dr. Dumindu Munidasa, consultant rheumatologist at Rehabilitation Hospital, and also Dr. Aruniha Pangama, the consultant psychiatrist in Ragama Hospital, and also the medical team in Ragama Medical Ward 8, and Ward 7 medical staff in our hospital, and last but not least, to our patient. Thank you.